Good morning. I'd like to introduce Massimiliano Valletti. He's our third-year resident and he will talk today about the injuries of the spleen. Thank you.
Good morning, everybody, and welcome to today's lectures about management of splenic injury in the adult trauma patient. Although epidemiologic data are still scant in the literature, we know that abdominal trauma account for about 10% of all trauma patients admitted in the emergency department. Abdominal trauma are more common than penetrating traumas, and patients are most frequently young and men than women. As Costa shows in his study from 2010, abdominal trauma patients are generally severe injured patients, as around 80% of the patients with abdominal trauma present with an injured severity score greater than 15. And an ISS greater than 15 occurred also in patients with abdominal trauma significantly more frequently than in patients with other kinds of injuries. Furthermore, spleen injuries together with liver injury account for about 85% of all abdominal injuries. And the splenectomy is the most performed operation in patients with abdominal trauma, representing about 50% of all surgeries. Road accidents are by far the most common cause of abdominal trauma, involving motor driver more than pedestrian, and other causes are in decreasing order: work accident, home accident, assault, and fall. Physical examination is an essential tool in the assessment in patients with abdominal trauma, starting with the ABCDE flowchart as the advanced trauma life support protocol suggests in every patient. In up to 90% of the patients with abdominal injury, we found abdominal pain, tenderness, and peritoneal signs. And remember that in up to 1/3 of the patient, the seatbelt sign after car accident can predict an intra-abdominal injury. We will now move on to the diagnostic imaging and classification. Speaking about focus assessment in emergency trauma patient, we have a choice between FAST and CT scan, and the management approach may depend upon the resources of the institution we are working in. If we look at the literature, we find mixed opinion in the use of ultrasound. As shown in this study, ultrasound as a low sensitivity is cause of mixed intra-abdominal injuries. CT scans are performed in almost all the cases to decide for operative versus non-operative management, and they conclude the study stating that ultrasound should be reserved for hemodynamically stable patients. On the other hand, the studies from 2006 show that CT was able to detect traumatic lesions in a large amount of patients without obvious clinical signs of injury, leading a treatment change in nearly 20% of the patient. If we suspect an injury and the patient is stable, we are able to perform an emergency CT scan in our resuscitation room to better detect abdominal lesions. In USZ, we perform in trauma patient an arterial phase of the thorax and the upper abdomen and a venous phase of the entire abdomen, which is especially important for the examination of the splenic patient. In fact, splenic parenchyma should be assessed in portal venous phase, as the arterial phase can mimic splenic laceration as shown in the picture above. Arterial phase is more useful to detect, for example, pseudoaneurysm or arteriovenous fistulas. The American Association for the Surgery of Trauma published a review of the spleen organ injury scale in 2018 that suggests a gradient of spleen injury from 1 to 5, depending on the extent of splenic hematoma or laceration from the radiological, operative, and pathological point of view. A grade 1 injury occurs when the capsular laceration is less than 1 centimeter or extension of the subcapsular hematoma is less than 10% of the surface area. In grade 2 injury, we have a laceration up to 3 centimeters, or the subcapsular hematoma extend up to half of the surface of the spleen. Furthermore, an intraparenchymal hematoma less than 5 centimeters can be observed too. In grade 3, we have a progression of the previous findings as shown in the picture. While grade 4 lesions are characterized by active intraparenchymal bleeding, vascular injuries, or segment devascularization. And as we have seen before, the arterial phase is very important to detect this type of lesions. The most severe injury, like active bleeding extending to the peritoneum or radiological signs of shattered spleen, are classified as grade 5 lesions. Now we will go through the management approach in traumatic splenic injury. We can divide the management principle into categories, a non-operative management and an operative one. If we decide for a non-operative management, we have to observe our patient, for example, on the IMC or the ICU, or we have to ask our colleagues from the interventional radiologists to perform a splenic embolization. If we choose for operative management, we have to decide if we go for an open or a laparoscopic approach, and then we have to decide if a splenic salvage is possible or if you have to go for a total splenectomy. The World Society of Emergency Surgery published in 2017 the guidelines for the management approach by splenic trauma. We will go now through the flow chart, and we have to divide the patient in stable and unstable patient. If hemodynamically stable patient, we have to perform a CT scan to be able to classify correctly the injury. In minor and moderate lesion grade 1 to 3, we can go for a non-operative management and observation of the patient. In moderate lesion grade 4 and 5, we have to perform an angiography and perhaps an embolization of the bleeding vessels. While in unstable patient with or without a positive test, we have to suspect a severe lesion and go for surgery. If we decide to observe our patient, we need a monitored care, serial abdominal examination, serial hemoglobin assessment, and the patient has initially bed rest, also if no clear benefits exist for this practice. A study from 2008 shows that the observation period of 5 days identifies at last 95% of all patients who would require some form of intervention. And yearly thromboprophylaxis may be safe, but there are no currently standards to the initiation of prophylaxis in patients who are managed non-operatively. Angiographic embolization was first used by Scalfani in 1981, and the success rate of this technique depends on institution, embolization technique, arterial accessibility, of course, operator skill, and type of embolization material. In the picture above, you can see at the top of the orange arrow a bleeding vessel during an angiography before the embolization was then performed. The indication to perform an arteriography with the embolization should be proposed then in every patient with hemodynamic stability, lesions grade 4 or 5, and aneurysmatic formation, and never forget hemoperitoneum does not represent an exclusion criteria to perform embolization. There is debate in the literature regarding the utility of follow-up imaging. In our institution, we perform a follow-up study if we have signs such falling hemoglobin, increasing abdominal pain, or fever. And for higher grade of injuries, 3 to 5, a repeat scan may be needed if the clinical situation is unclear. In one survey of the American East members, 85% of the responders did not routinely do re-image in patients with splenic traumas. On the other side, a multi-institutional study from 2013 shows that performing a CT scan during the first week post-admission detected pseudoaneurysmatic formation in up to 50% of the patient. Speaking about resumption of physical activities, we restrict our patient from sport activities for 3 months after discharge, and re-imaging may be indicated to lift, for example, on a high-risk activity restriction. In a study from 2008, a radiological healing was demonstrated in 80% of the patient within 2 months after injury. Now about the surgical management of splenic injury. In up to 40% of the patient with splenic injury, we have to perform surgery, and the open surgical techniques are current standard of care. While laparoscopic techniques have been described only in case reports and small series, and there are no current recommendations to perform a laparoscopic approach in trauma patients with splenic injury. First of all, we have to decide if we have to perform a total splenectomy or a splenic salvage, and the decision is made upon grade of injury, presence of associated injury, patient's overall condition, and of course experience of the surgeon. Splenic salvage was mostly practiced in the 80s and in the 90s. However, splenectomy is today more common used, likely because more low-grade injuries are today treated with an observation. If we want to perform a splenic salvage, we have to decide if the patient can tolerate a rebleeding or not. If the answer is yes, we can propose a splenic salvage. And if the answer is no, we have to go to total splenectomy. The last chapter of our lecture will describe the surgical steps of open splenectomy and splenic salvage. In step 1, during the first step of open splenectomy, we have to enter in the lesser sac and identify the splenic artery near its origin to the celiac axis, which accessed through the gastrohepatic ligament. In the second step, we have to open the gastrosplenic ligament through an avascular area and proceed to dissect the short gastric vessels. The spleen is then progressively retracted medially to identify the peritoneal attachments, which are divided proceeding from the inferior pole to the superior pole. While dividing splenic attachments, always attempt to stay closer to the spleen than to the opposite structure. With the assistant holding the spleen, the surgeon can now separate the tail of the pancreas from the splenic vessels. Now we divide the vessel proximal to the bifurcation between clamps and apply suture ligature to each after removing the spleen. We first clamp the artery and then squeeze the spleen in order to promote autotransfusion of splenic blood prior to clamp the vein. Once the spleen is removed, the abdomen is closed with or without a closed suction drain. Splenic salvage can be performed in a selected class of patient with grade 2 to 4 injury and hemodynamic stability, no coagulopathy, and CT confirmation of an isolated splenic injury. If we go for splenic salvage, there are two main techniques. We can perform a partial splenectomy or a splenectomy. If you perform a partial splenectomy, the splenic fragments can be transected with combination of scalpel or monopolar cautery. Very important is to make sure to leave 5 millimeters of devitalized tissue in situ in order to ensure a properly hemostasis. If injury is to a single pole of the spleen, we can perform a splenography and a pledge repair should be used because the splenic capsule in adults will not hold a stitch in the most of the cases. Prior to tying the knots, a fibrin glue should be applied to ensure once more a properly hemostasis. An additional technique can be used in conjunction with pledged repair or alone, and is the use of a mesh. After application of fibrin glue, the mesh is closed with a running absorbable suture around the spleen. Care is taken to ensure that the mesh is tightly applied and the adequate opening is left at the ileum to preserve a good blood supply of the organ. To summary, do a properly physical examination in every patient you see on the emergency department with a blunt abdominal trauma. Focus assessment with a CT scan in hemodynamic stable patient has to be done. For low grade 1 to 3 injuries, we suggest a non-operative management. And remember, immediate operative intervention should be done for patient who develops hemodynamic instability. Thank you for your attention.
Yeah, excellent presentation. Thank you very much, because this is a type of injury you can kill patients, and I think we need to do certainly not too much, but it's very dangerous not to do enough here. There are guidelines, usual guideline, which is very important in terms of teaching and whatever. These guidelines, however, are level 5 evidence, and sometimes we can go for that. And for me, which I have some restriction, and we have some conversation here we discuss, which is the embolization. I mean, it may make sense thinking that with a bleeding you do it. Maybe I don't read this literature enough for sure, but I have zero evidence that the embolization as a routine, I mean, we imagine some selective case with active bleeding, I don't know, but as a routine or as a recommendation play any role in the management of this, and I know this is used in many centers. I think the American also use it. Of course, you need the people, you need the interventional radiologist. I mean, imagine you lose time, etc. I think I don't really see this, so I would maybe ask to comment on that, and then we may have a few other questions regarding preserving in surgery here. I think when you evaluate a trauma unit and you see they do only splenectomy, you have a little bit concerned about quality of what's going on. On the other hand, there is enough probably today less trends in trying to keep the spleen, because if it will bleed, if there is, etc. But there are some situations where really we need, and I think the mesh, for example, is a good technique. We have now the bipolar radiofrequency that we can use, Laquamantis, that is useful in liver and in that, and combining this, and of course that needs to be done by people with a little bit experience in this kind of techniques. But maybe my first question, the debate is about the role of embolization in managing these patients.
The recommendations are very weak, to be honest, and the problem is that about 2/3 of our patients are polytraumatized patients do have a severe brain injury, and they don't, let's say, react very good on rebleedings of splenic injuries. And that's the reason why we are rather into splenic embolization, because we are afraid of a rebleeding. But to be honest, it's always a discussion. Just this weekend we had a discussion. There was a patient, she had a splenic injury grade 2. To be honest, basically the patient doesn't need an embolization, but she had a severe brain injury. So we proceed with prophylactic embolization with a proximal arterial embolization. And it went well.
Thank you very much, Massimiliano. Great talk. Just a comment regarding surgical approach. There was some mentioning of laparoscopic surgery at the beginning of the talk. It's my feeling that laparoscopy plays a minimum, if at all, any role in this type of injuries. Or has there been any change, the role of laparoscopy? No. So I think nobody should feel obliged to do diagnostic laparoscopies in patients with splenic injuries.
So perhaps if you have previous embolization, it might be you have a quiet spleen with a severe injury which you have to take out, then might be justified, right, by minimal invasive surgery. So yeah, I have a question for all these embolization spleens. When you take out the artery, is there any long-term follow-up data? What happens to the spleen? It should be.
Just recently we looked at our data, and we have about 24 prophylactic embolization. 23 cases went well. One case had a dissection of the truncus, as far as I remember, and we had to do an operation of the abdomen and take out bowel, and had some issues. And I remember 2 or 3 cases having an MRI with a completely normal spleen at follow-up.
I think I wonder whether we should have our own guidelines here in some way. What do we do in-house? Not that this is like the Bible and everybody, but I think it could be good to have, that is not the purpose of this, to have that, but maybe a small group to discuss a bit these guidelines.
Great talk. Concerning the operative technique, because in my experience, splenectomy can be quite easy if the patient is slim, if the spleen is mobile, and you can easily get it out of the left hypochondrium. But there are other patients, obese patients, very deep situs, also the stuck spleen in the back, which you can't really get out. And as far as I was taught, there are 2 approaches. You showed the anterior approach first, so you divide the gastrosplenic ligament first, and then you go to the peritoneal flexion behind and try to get the spleen to the midline. My experience was a lot easier, was to try to get the posterior approach first, to mobilize the spleen to the midline. Then you have also a kinking of the vessels in the hilum, and also already during mobilization a reduction of the bleeding. And this is, in my experience, a good approach even in difficult situations where the spleen is not obviously there when you open the abdomen. And there's also a question, if you have a CT scan prior and you have an isolated splenic injury, no other injury, would you go via median or would you go via transverse laparotomy?
Well, just maybe one, just for the, how to approach that. Of course, you have the dramatic situation when it bleed in an obese patients. You go here, you have almost 100% chance at the end that you will have a partial pancreatectomy when you cut, you have fistulas, etc. So the technique, if you can do it the way it's described here, meaning you are not in an unstable patient dying on the table, then I think it's very nice to go to the artery first, which is easy to find here. Just go above, find the artery, put a clamp or whatever you can do, ligate that, and then a good part of the bleeding will stop, and then we can do more electively. And I think not many, we don't have so many, so even surgeons have not a huge experience with this spleen, and that's a dangerous, the surgeon not too much experience in the bleeding and go and try to go behind, it could be a disaster also in this situation. But it's clear that the thin patient, you can just go slowly, just lift up that, and then you have everything in your hand and take your time. In terms of the maybe I think, and you can also give the answer that, if you have an unclear abdomen, you do a midline, a big midline, then you have access to everything, and you can go The other side, if you're pretty convinced or you have all the evidence from the CT that you have something that's really localized in the spleen, then you have an advantage, in my opinion, to do a transverse. But in the trauma, I think we should never blame someone who go for a midline laparotomy.
I completely agree. We would always go for a midline incision. Sometimes you're astonished to see some other stuff, meso, small bowel, CT scan was normal, and then you have a hole somewhere. So we prefer the midline incision. For the laparoscopic stuff, indications to take out the spleen, as we said, was hemodynamic instability, and I think in unstable patient it's clear that laparoscopic approach is not an issue. But after embolization, if there is an indication to take out the spleen, abscess or stuff like that, then I think it's up to you what you choose as an approach. The robot is fantastic, so we can publish this.
Good. Thank you.